All right, so good theme today, hopefully. Uh, Everybody, I think probably remembers last fall in 2020, we talked about this Great Barrington Declaration, which essentially was the product of a number of physicians or scientists from prominent universities in the US and the UK and other places that essentially advocated the strategy of allowing infection to essentially proceed unchecked in younger populations while focusing on protecting the elderly and vulnerable through means like restricting access in long-term care facilities, eventually vaccination, which they did endorse. But as we talked last year, this was really the failed strategy that Sweden had tried to use of essentially allowing the pandemic to achieve herd immunity in a population and thinking that you could protect the vulnerable in that population while allowing infection to rage in the rest of the community. And that strategy proved to be unfortunately devastatingly wrong, which Sweden eventually admitted and moved to a more conventional strategy. In the US, that gained a lot of traction and support. And so in many ways, it is somewhat the strategy that many states adopted. And unfortunately, the product of that was about 650,000 dead Americans between when the Great Barrington Declaration was signed on October 14th, 2020, and where we are today. So I think that should probably demonstrate the wisdom or lack thereof associated with that strategy. So just when we thought, and that Great Barrington Declaration has made a series of comebacks, and even recently with Omicron saying, aha, now we really should adopt this strategy. And I think we're seeing some of the results of that with healthcare systems being overwhelmed and school transmission at an all-time high, and also the number of kids and young adults in the hospital at an all-time high. But just when you thought you couldn't get a strategy more wrong or misguided than the Great Barrington Declaration, Dr. Robert Malone and his friends from the Physicians' Declaration have said, hold my beer, because we now have this new declaration that was apparently the centerpiece of the March to Defeat the Mandates, which happened a few days ago in Washington, if you all were paying attention, where a few thousand folks gathered on the National Mall. And you can read all about it and how Dr. Malone's Physicians' Declaration was influential in an article written by Dr. Malone. But it describes the basic premises of the Physicians' Declaration, which has received a lot of attention in social media circles, certainly, which is essentially three faulty assumptions: that children, again, have negligible risk from COVID. Tell me where you've heard that before. That was from Great Barrington Declaration. That we are denying herd immunity and natural immunity by pursuing these other non-pharmaceutical interventions. They point to lockdowns, and obviously I'll have you note, nobody in the US is doing lockdowns or anything even approaching lockdowns. In fact, most of us aren't even doing masks. So I'm not sure how we're denying natural immunity, maybe through vaccines, but they argue that vaccines don't work. So it's difficult to understand really the logic behind this. But essentially their point is similar to the Great Barrington Declaration. We should just allow the pandemic to infect everyone, achieve herd immunity, and will therefore have endemic status and everything will be fine. And then we're also apparently preventing people from having access to these cures, which are essentially 100% curative. And I'm not sure what those refer to. It doesn't specifically talk about whether these are the things like ivermectin, hydroxychloroquine, and others that have been thoroughly debunked by actual scientific studies. But nevertheless, these are the principles upon which the physician's declaration is based. And again, they bring back a lot of the previous myths that people have been desperate to cling to about COVID-19. So the first is this myth that children face negligible risk from COVID. And I've talked about this a number of times on a number of different morning briefings, so I won't go into a lot of the details that I've already discussed, but I will talk about this CDC estimate, which came out, I think, late November. I had talked about this many months ago. The CDC periodically updates this estimated COVID-19 burden. And they do this by looking at what the reported numbers of cases and hospitalizations and deaths are, and compare it to what are probably, by best modeling estimates, the true numbers. And remember, we've talked about the fact that we under ascertain cases dramatically in much of the US. And I think everyone out there can certainly appreciate that in Nebraska, where even if you have symptoms and you really feel strongly that you have COVID and you really want to get a test, it's very difficult for you to get tested and get a result in a timely fashion. And so often people just don't get tested, and often people choose not to get tested because, for many different reasons, they don't want to know, or they don't believe that testing is useful or real. And so CDC has estimated that overall, it's still about a 1 in 4 case ascertainment rate that we have across the US. And as I've talked about previously from other calculations that I and others have done, that's probably about where I would peg it as well. And that under ascertainment factor changes depending on the population specifically. So in some parts of the country, the East Coast, specifically in the Northeast, where testing is a lot easier and much more embraced by the community, that under ascertainment rate is much lower. In the parts of the Midwest and in rural Nebraska, where again, it's very hard to get a test, that under ascertainment is likely much higher. And obviously it changes by age and circumstance as well. So if you're an 80-year-old living in a nursing home, your under ascertainment is almost negligible, 1-to-1, right? Because those folks are getting tested frequently, usually more than once a week. If they get the sniffles, they're getting tested again. And so we probably don't miss that many infections in that population, where we're looking a lot harder. If you are a 19-year-old young person, who's working a regular job and can't take time off and don't have access to free testing, we probably miss many, many, many more of those infections, right? So maybe it's 1 to 10 or 1 to 15 that we catch, and the same is true of school children. So when you look at all of those data in aggregate, and then estimate what the true infection rates have been across different populations, this is what the CDC arrived at. And again, only through the end of September 2021. So certainly incorporating part of the Delta wave, but many states had really only just started to take off with Delta by the end of September. And obviously none of the Omicron cases that we've accumulated here over the last month and a half. So you can see that overall, the CDC estimates that in kids, there had been almost 26 million true infections over the course of the pandemic up until the end of September. Only 645 deaths, thankfully. So again, it remains, even with this estimate of true burden, the numbers are relatively close to what's reported. And thank God we have very few, relatively speaking, pediatric deaths from COVID-19, although I will note that's still many more than we would expect from 2 average flu seasons. And so even from a perspective of deaths, the number is much more than what flu would give us. But I think the important number here is to look at hospitalizations. So over 266,000 kids are estimated to have been hospitalized from COVID-19 since the beginning of the pandemic, March of 2020, essentially. That's a lot of kids that have ended up in the hospital and will have potentially significant impact in the short and long term. As it does appear that the more severe your symptoms, the higher the likelihood is that you will develop long COVID. So again, that burden on children is not negligible. It is in fact quite significant. And we've already talked about the burden of kids who've been orphaned, or at least lost one primary caregiver from COVID, which ranges in the several 100,000 by estimates. And so the impact on kids has obviously been dramatic. Now, those children who have been hospitalized, that 266 odd thousand, again, are at risk for significant long COVID and other morbidities that may last a while. And this paper recently came out looking at neurological symptoms and deficits in children who were admitted to the hospital with SARS-CoV-2 infection, COVID-19, or with MIS-C, the multi-system inflammatory syndrome from COVID, showing that almost half of that cohort had at least one significant neurological manifestation. A significant proportion, well over 25%, had more than one. And the most common were headache, as you see here, and maybe not that big a deal, but acute encephalopathy was seen in around 20% of those kids. So a little lower in kids who were admitted just with garden variety COVID-19, and over 20% in kids who were admitted with MIS-C. That's a pretty high incidence of acute encephalopathy. And people who are admitted to the hospital, and kids admitted to the hospital who have encephalopathy, often have some longer standing deficits and some permanent deficits if we're looking at kind of kids across the board. It's also true that, again, we continue to learn more and more about long COVID in kids in general, and not only those who were admitted to the hospital, but in all comers with pediatric infection. This was just recently published in the American Academy of, or the Association of American Medical Colleges, AAMC, that kind of did a summary of what the literature has been showing. And again, probably lower than 10%. I think if you take the aggregate average of all of the studies that have looked at long COVID in kids, but certainly higher than 5% for all comers. And you can see the range is from 2 to 50% in studies. And so it's clear that there are kids who are significantly impacted by long COVID that may have long-standing deficits, at least that can last for months and certainly impact their development and learning. So if we go backwards here, let's look at that 26 million cases almost of COVID-19. So if only 5% of those kids are having long COVID like symptoms, that's we're talking six figures, right, in terms of kids across the country who may have had significant problems there. We also know that in kids, Omicron variant is having a disproportional impact. These are data from every geographic region in the US showing that once school went back in session after Christmas break, we see a dramatic jump in case counts in school-age children, really in every geographic region. It may be that in region 1, that's starting to come back down, but everywhere else looks like that's still growing. So the pediatric population, this is in proportion of cases compared to the rest of the demographic population. So you can see that kids appear to be on the rise and driving transmission in all of these regions, again, since school went back in session, and we know that school is a high-risk environment. Here's another myth that this Physicians Declaration and the Barrington Declaration and others, are holding fast to, that if we only reach herd immunity, then everything will get better. And I think that should have been debunked a long time ago. And we talked quite a while ago, a year ago, about the fact that communities that had already appeared to have reached levels of herd immunity, like Manaus in Brazil, before the advent of Gamma, who achieved about 75% community attack rate, which should have had theoretical herd immunity for Gamma. And other communities in India and even parts, neighborhoods within the US and Europe had very high community attack rates and still had huge outbreaks with Alpha variant or Delta and other later variants. And so in the US here, you can see that, our seroprevalence rate, if you're looking at blood donor study, shows that for combined seroprevalence, that means probably both from natural infection and vaccine, we're well over 90% of people who've either been infected or have received the vaccine. And so that should be well above herd immunity threshold, even for Omicron, given what we estimate the R naught is. And clearly that's not put a big dent in Omicron's ability to spread quickly through the community. Now you can argue that blood donor data doesn't necessarily accurately mirror the rest of the country or doesn't provide a accurate representative sample. And that's true. Blood donors tend to be healthier and younger, but you can see that those seroprevalence data hold true even more so for people over the age of 65. And that's probably because of high rates of vaccination in that group. But we've already achieved, at least if you believe vaccines and natural immunity, natural infection can protect you, we've already achieved rates where we should be at herd immunity threshold. Now, if you look at the other CDC large sero survey data that they're looking at, this is from commercial laboratories taking blood tested for other purposes and then running serology tests for COVID-19. And this is actually, if you look at the arrow up at the top there, this is specifically serology, sort of antibodies against the nucleocapsid protein of the virus. So this is not a protein that is contained in any of the 3 vaccines that we use in the US, right? Those are all directed against spike. So if you have antibodies against N protein, you have seen the real virus and you have natural infection. So what's estimated from September, if we turned the clock back a bit, looked at that seroprevalence data from across the country, then you can see that they estimated a little over 29% at that time in September had been infected with the virus, and that translated to about 87 million cases countrywide. Now, if you take at the same time data from that COVID-19 burden modeling study that the CDC had done, where they estimate 147 million cases at that time, you get that this serology data probably underestimates true rates, if you believe that modeling, and the midpoint of that by about a factor of 1.7. Now, why would serology underestimate that? I think for a couple of reasons, but probably most prominently is serostatus tends to degrade over time, right? And especially probably in older folks. If you were infected in March of 2020, the likelihood that you have antibodies from that infection that are detectable still 18 months later is potentially quite a bit lower. And we see that in that lower graph. You can see that over time during the spring of 2021, the late spring and into summer, antibody prevalence actually declined in that population. And you can see also in the upper arrows there that for folks over the age of 65, antibodies against natural infection were well below less than half what it was for kids. Now, I think it's true that kids have been infected at a higher rate. I'm not sure it's twice the rate. And so I think some of that is potentially due to the fact that as you get older, antibody titers tend to decline sooner. We've seen that certainly with a lot of the neutralizing antibody studies for vaccines. So it does kind of make sense. So then if you look now at the data for November, which is the most recent we have, it would estimate that 31.6% had antibodies against N at that time from this study. And if you multiply it by that under ascertainment factor, that would give you an overall attack rate of over 50%. So that aligns with some of the other data we've talked about before, that it's probably true by the end of the year that over half of Americans had already been infected with one form of the SARS-CoV-2 virus or another. And certainly a large proportion of people have been infected between November and now with Omicron. And so again, we should have already essentially achieved theoretical herd immunity rate, or certainly close to it, even if you believe that vaccine only gives mild protection, because certainly we have now a relatively significant number of folks who've been boosted, and all of the data from vaccination and boosting indicate that it has good protection. Now, this idea of natural immunity is one that's again been enthralling to people for a while, and this study just came out a couple of days ago and sent social media into a frenzy. Talking about how the CDC has finally confirmed that natural immunity is far superior to vaccine imparted immunity. And those who've been participating in this call for the duration of the pandemic know that early on, I actually thought that natural immunity would provide superior protection against future infection compared to vaccines, because historically it's been rare that we've been able to have vaccines with superior immunity to natural infection. But the data over the last year and a half has clearly borne out that these new vaccines that we have provide much more robust and long-lasting immunity than does prior infection. And the two studies that have potentially contradicted that are the one study from Israel that I went over several months ago and explained why there's significant biases in that study that make it really impossible to interpret and should not be relied upon to provide convincing scientific evidence. And I think the same is true in this study, but we'll talk about why. So this study had cohorts from California and New York, and this is essentially a retrospective cohort study where they saw who had been vaccinated by spring last year, I think by the middle of May, and who had been diagnosed with COVID-19 before March of 2021. And then looked at people who'd been vaccinated and had either been infected previously or not, and unvaccinated and who had been infected previously or not, and compared age-adjusted rates. And what they found is, to no surprise, I think, people who were unvaccinated and had no evidence of prior infection seemed to have much higher risk of infection than the other categories. But the three other cohorts seem to be pretty close together. And even recently, it appeared from their data that potentially people who had been infected previously but had not been vaccinated had immunity that was superior to people who had been vaccinated but had not experienced a previous infection. And so this was reported as people who had been vaccinated without previous infection had 6.2-fold or 4.5-fold decreased rates of cases compared to unvaccinated, uninfected. But if you had been infected, even if you hadn't been vaccinated, you had a 29 and 15-fold essentially increase in your protection. So significant increase over unvaccinated. The highest level of protection was indeed found in this study in people who were vaccinated and also had been previously infected. But there's a couple of important caveats to take into account. First of all, this study did not take into account boosting and what the impact was the third dose of vaccine on level of protection, which we certainly know for many high-risk people is true. The other thing is that when you start looking at the actual data, some interesting trends emerge. So this is the hazard ratio compared to, on the left, unvaccinated with no previous COVID diagnosis. So if you, let's look at that top line in May, starting in May and going through early summer. If you were vaccinated but had no previous COVID-19 diagnosis, early on in May, that appeared to give you essentially a 21-fold increase in protection. Now that dropped considerably over the first couple of months of the study. So into the middle of the summer, now you only had around a 7.5-fold decreased risk of infection compared to an unvaccinated, previously not infected person. If you look at people who had a previous diagnosis but weren't vaccinated, that level of protection went up dramatically over those few months, which is interesting because you're obviously becoming more and more remote from your prior infection. And so you wouldn't necessarily think that your level of protection would go up over that time. If anything, we know that for vaccinated people and for people who've been previously infected, your antibody titers and your T cell responses probably go down within months after being infected. You could argue potentially that perhaps for some reason the vaccine is less able to protect against Delta and more able to protect against Alpha. So most of the cases in that May-June timeframe were probably Alpha in New York and California, and most after July were Delta. But then you would also have to argue that for some reason natural infection with a previous variant was better at protecting you against Delta than it was against Alpha, and Delta seems to be drifted somewhat farther, although that could potentially be true. The weird thing is you also see this trend in people who were vaccinated and had previous infection. And if you compare those two groups of vaccinated, no previous diagnosis, or previous diagnosis, then a really weird trend emerges. And it seems to indicate that vaccine actually gives you negative protection, right? So there's no reason why, and no study currently suggests that vaccine plus prior infection gives you less immunity. It always gives you more. In all of the studies we've seen, if you're vaccinated and you've been previously infected, your neutralizing antibody titers are much higher, your T cell responses appear to be higher, and your level of protection in epidemiological studies has been higher. So this makes no sense, right? There's no reason why you would expect a vaccinated person with previous infection to have lower levels of protection than a vaccinated person who had no previous diagnosis. And this goes to the biases that are potentially inherent in these types of studies. It's clear that people who were vaccinated are very different from people who were unvaccinated once you got to spring and summer. Everybody who wanted to get a vaccine could. So clearly there's a tremendous amount of selection bias involved in who is presenting themselves to get vaccinated and what circumstances are surrounding that decision. Certainly a lot of people who were in higher risk groups, people in nursing homes, et cetera, had very high vaccination rates in New York, in California, well over 95%. Whereas other people who were over the age of 65, but not in long-term care facilities, had lower vaccination rates. And there's lots of different factors that went into that. Now, it's also true in New York. You can see that significant difference in vaccinated, prior infected, vaccinated, not prior infected is manifested there too. So these data apply, this data anomaly applies in both circumstances. The other thing to keep in mind with this study is that ascertainment bias that we talked about, right? So we know that we only probably catch 25% of real infections. And if you look at populations that differ in their behavior, right? So vaccinated people or people with prior infection may have very different motivations and very different likelihoods for presenting for testing compared to people who have not been vaccinated and not been previously infected. There's also a lot of socioeconomic and demographic differences in minority populations and patients that have limited access to testing, that had very limited access to testing early on. When you remember, up until through the winter wave of last year, we had testing shortages across the country. So if you were in a minority community or in a disadvantaged community, and you had, if you were an essential worker or worked in a service industry, you may not have had the ability to go get tested, whereas the access to testing opened up quite a bit more by the summer of 2021. So all of these things really need to be taken into account when you're looking at those cohorts. And again, even in hospitalization data, that huge difference between that group that's vaccinated with previous diagnosis is seen compared to vaccinated with no previous diagnosis. So again, this makes absolutely no sense. There's no plausible biological explanation for why vaccination and previous infection would give you lower hospitalization rates. In fact, again, every study we've seen that looks at these data indicates that people who've been vaccinated and have a prior diagnosis have much higher levels of protection. So at baseline, when this cohort started, there was something very wonky about these two comparison groups, and that really throws all of the conclusions of the study, I think, into suspicion. So as we talked about with that Israeli study and others, you really need to be careful about the biases that are introduced into retrospective cohort studies, things like detection bias, right? Who you actually ascertain are true cases, because behavior contributes a lot to how that detection is done. Selection, so who is entered into those cohorts from the beginning, because it depends a lot on whether people chose to get vaccinated, whether they choose to go get tested. Survivorship bias, which we talked about with the Israel study, was a huge issue, right? A lot of people in that unvaccinated group Probably by the time counting started in late May, if they hadn't been vaccinated, many of the highest risk people who lived in nursing homes, for instance, who might be the most prone to get infected and end up in the hospital, had already died. So they can't be counted, and that skews the results going forward. You also need to beware of studies where their findings contradict the overwhelming amount of evidence, right? So we've seen from multiple studies that vaccine imparted immunity, at least prior to Omicron, and now with some studies in Omicron, gives you better and more durable protection than natural infection. Doesn't mean natural infection doesn't give you protection. Of course it does. It's just that so far the studies that are well constructed and designed seem to indicate that vaccine gives you more reliable and longer lasting immunity. And now certainly with the boosters, that's the case. And then you also need to be very careful about studies that have data anomalies like this one that make absolutely no sense and seem to defy, again, all of the other knowledge that we have about this situation. So I would caution danger, Will Robinson, in touting this study as the final definitive evidence that natural infection gives you better immunity than vaccines. What we do know is the data, and I'll plug Matt's analyses again, because I think he's done an amazingly good job looking at the data from Nebraska, which have now been mirrored by other studies nationally, showing that your best protection is to be vaccinated and boosted. So 11 times less likely to be hospitalized for COVID-19 recently, right? So that's with Omicron, if you were vaccinated. And we know that a significant proportion of that unvaccinated group in that calculation had to have been infected, because we're well above 50% now of people who've been infected with COVID-19. I would argue that for unvaccinated, that proportion is probably quite a bit higher, because those folks in general have not taken the same levels of precautions that people who have been vaccinated. So that comparison already takes into account a large degree of natural immunity. And then obviously boosting has dramatic improvements on protective efficacy. And so that's why to be considered fully vaccinated now, I think most experts would tell you, you have to have the third dose or booster dose. And as Matt pointed out from last week, that in Nebraska gave you a 46-fold reduction in hospitalization. So the data still seem to be clear that natural immunity, while certainly gives you some protection, is probably not as protective as vaccination, clearly not as protective as vaccination with a third dose. And so nothing has changed really in what our assessment is. And we should be very strong advocates in pushing back against these false pretenses of letting infection rage to achieve natural immunity. That has been shown again and again to be a debunked and false belief, and one that unfortunately has given us over 860,000 dead US citizens, and we are still going up precipitously, unfortunately. So that's all I have. Thanks, Shelley.